Hi, I'm Dr. Glen Cook. I'm a clinical neurophysiologist and autonomic disorders specialist at Walter Reed National Military Medical Center in Bethesda, Maryland. This is a brief talk providing an overview of disorders of the autonomic nervous system. I hope that it's beneficial and that you enjoy this talk. So you know the topic for which we are here today, and that is to talk about the autonomic nervous system. We're gonna cover a lot of material. To some extent, it's gonna feel a little bit like information overload. That's okay. Soak in what you can. Take notes if you want to. If you have questions, write them down so you can ask them. We're going to have plenty of time for question and answer. That's a big part of what I want to do today. I want to make sure that there's a conversation here. I want to make sure that the questions that you have are answered. Because again, a lot of stuff I'm going to cover very superficially. You heard about me. I do work for the government. And nothing in here reflects the views of the U.S. government. I don't have any pertinent financial disclosures. You can read what we're talking about here. What I want you to walk out of this room knowing is two things. One, I want you to have a sense of the neuroanatomy of the autonomic nervous system and how that plays into symptoms. The other thing that I want you to walk out of this room having is a sense of hope. And I want you to know that while a lot of things that we group under the rubric of autonomic disorders don't go away, so again, while a lot of the things that fall under this category don't go away, we can get a lot of benefit with treatment. Okay? So there's hope. And that should be a big part of the message today. We're gonna go through the discussion, not the talk, kind of in this way. We're going to talk about background of autonomic disorders. We're going to focus a lot on autonomic nervous system anatomy. Okay, so I'll try not to overwhelm myself or anyone else. We're going to talk about how we do testing of the autonomic nervous system, and then we're going to highlight some of the common disorders that we categorize as dysautonomias. We'll talk about some of the laboratory evaluations that we typically think of, and we're going to talk about treatment. You're going to see a lot of illustrations in here that were done by my mentor in autonomic medicine, Dr. Goldstein. Most of these are available in his ebook, which can be downloaded through his website, his NIH website. All right, here we go. Okay, a lot of words on this slide. Numbers about how often things that we call dysautonomias happen. What's a dysautonomia? So dys means
Dysautonomic of the nervous system.
Yeah, so dys, inappropriate. Autonomia, relative to the autonomic nervous system. That's a lot of stuff, right? Anything involving the autonomic nervous system, we'll talk more about what we categorize as autonomic nervous system. Anything going wrong there, we can call it dysautonomia. That's a very broad umbrella term. And it happens a lot. You can read the numbers here. But if we look at it graphically, where the diameters of these circles are representative of the prevalence of different medical conditions, well, fainting, syncope happens a lot. Lots of people faint. I know lots of people in this room faint. Lots of people in general faint. It happens. Irritable bowel syndrome and chronic obstructive pulmonary disease, so COPD, not an autonomic disorder, but on the slide to show relative orders of magnitude. We look at postural tachycardia syndrome, roughly on the same order of magnitude of breast cancer. More people have breast cancer than have POTS. But again, same order of magnitude. Parkinson's disease, a little bit less than POTS, kind of in the same ballpark. A lot more than people who have multiple sclerosis. And as you look at the relative prevalence of these diseases, and then think about how much attention is paid in medical and graduate medical education to these diseases, it's not surprising that for people with autonomic disorders, there's often a long delay in diagnosis. So historically, it's taken people with postural tachycardia syndrome an average of 6 years to get diagnosed. More recent data, we're down to around 4 years. So, hey, things are getting better. That's good. People with multiple system atrophy, average time to diagnosis from onset of motor symptoms, 6 years. And for people with postural tachycardia syndrome, the average number of doctors seen before getting diagnosed, 7.3. That's a lot. And I know a lot of you in this room have been through this. So I know you can appreciate the struggles that involves. You're not alone, and these numbers reflect that. Okay, so that's kind of burden of disease. So let's talk about what is the autonomic nervous system. So that term goes back a little over 100 years to John Newport Langley, who coined the term the autonomic nervous system. Why did he use the word autonomic? Well, he was describing the fact that these functions of the nervous system aren't under voluntary control. They happen autonomously or automatically. That doesn't mean independent. So all of these functions are highly integrated with one another and everything else that we do. For example, if I choose to squeeze my fist and tighten up the muscles in my forearm and hand, my blood pressure goes up. Skeletal muscle activation boosts my blood pressure. Highly, highly integrated pathways with each other, with volitional movement, with mood and behavior. Langley recognized 3 components of the autonomic nervous system. What he termed the sympathetic nervous system, because it makes you a very nice person. No, that's not what it is. So the Greek term sympathy means in harmony. That was the term goes back to the ancient Greeks, who recognized these structures that ran along the vertebral column were responsible for helping, at least their thought was, they helped the body work in harmony with itself. And John Newport Langley went, yeah, it does. And so we call it the sympathetic nervous system. We recognized there was another component, the parasympathetic nervous system. And he described the third component, the enteric nervous system. So the gut part of the nervous system, that part of the gut that is under its own autonomous, though highly integrated regulation. So those are the 3 things that he recognized. A few years later, Walter Cannon came along. Walter Cannon was an interesting character. He was the guy who coined the term fight or flight. So when you hear that term, you think of Walter Cannon. He recognized, like, hey, the sympathetic nervous system does stuff, but there's other stuff going on in the body that's not coming from the nerves. It's actually coming from the adrenal glands. And these adrenal glands are doing something related, but separate from the sympathetic nervous system. So when we use the term glands, we use that term for parts of the body that are involved in hormone production. Well, how does that relate to the nervous system? What's kind of cool about these cells in the adrenal medulla, they make epinephrine, adrenaline, a neurotransmitter. Those cells actually come from neural crest cells, the same cells that neurons come from. So the sympathetic adrenergic system, which is housed in the adrenal medulla, those are actually neurons that forgot they were neurons. And instead of dumping their neurotransmitter at an effector site, they dump it into the bloodstream. And that's what adrenaline is. So sidebar here, adrenaline is the same thing as epinephrine. Noradrenaline is the same thing as norepinephrine. So why 2 terms? It's just Greek and Latin, just to make things extra confusing. So These organs live up on the kidneys, epinephros. Who speaks Greek in here? Good. Good, then I can make stuff up and no one will call me on it. So, epinephros upon the kidneys. The Latin form is adrenal, next to the kidneys. So adrenal, so adrenaline comes from the adrenal glands. Epinephrine comes from the glands that are upon the nephros kidneys. So when you hear those two terms, and I say this because I'm going to go back and forth when I'm talking today. So I say that so you can keep track of it. Adrenaline is the same thing as epinephrine. Noradrenaline is the same thing as norepinephrine. End sidebar. So a few years after Walter Cannon's work, and these three actually overlapped, Sir Henry Dell came along and said and recognized that sweating in humans is controlled by the sympathetic nervous system. But instead of using norepinephrine or epinephrine, that sympathetic function is releasing acetylcholine. So it's a sympathetic cholinergic system. So that sympathetic cholinergic system is releasing acetylcholine at its effector site. We talked about the adrenal medullary cells releasing epinephrine, adrenaline, into the bloodstream. We talked about the sympathetic neurons, the sympathetic noradrenergic neurons, releasing norepinephrine at their effector site. The parasympathetic nervous system releases acetylcholine at its effector site. What about the enteric nervous system? There are all sorts of neurotransmitters in the gut. There's actually more serotonin in the gut than there is in the brain. Lots of dopamine in the gut, lots of acetylcholine in the gut, vasoactive intestinal peptide, nitric oxide, etc. Lots of stuff going on in the gut. And all of these functions are regulated by structures in the brain and in the spinal cord, what we call the central nervous system. And those central nervous system structures communicate to the rest of the body through the peripheral nervous system. These neurons that come out of the spinal cord and go throughout the body. The brain regulates autonomic function through a network of centers that are highly connected with one another that we call the central autonomic network. And all of that regulation feeds down into the brainstem and into the spinal cord, and then is sent out into the periphery. So you can think of the neurons of the peripheral nervous system as like the transmission wires that bring electricity to your house. So you've got like the power substation in the central nervous system, and then the wires bringing the electricity to your house. And this figure, I want you to kind of keep this in mind. You don't have to memorize it, but this is important to some of the testing, but also to the medication therapies that we're going to talk about in a few minutes. So what are these components of the parasympathetic nervous system? Well, it's the vagus nerve, which comes out of the brainstem, and then sacral parasympathetic nerves that are coming out of the very bottom part of the spinal cord. Those parasympathetic neurons, it's a two-step process. There's one neuron that travels a long ways and then communicates to a short neuron near the effector site. Those neurons communicate, the upstream neuron communicates with the downstream neuron using acetylcholine. And like we talked about previously, those parasympathetic neurons use acetylcholine at their effector site. Whether it's vagus nerve parasympathetic activity or sacral parasympathetic nerve activity, it's the same. Acetylcholine at the synapse, where the neurons talk to each other, acetylcholine at the effector site. When we look at the sympathetic nervous system, the first order neuron is a short little neuron that synapses in one of those ganglia that those ancient Greeks recognized and called sympathetic. There's a synapse or communication between neurons there, again involving acetylcholine. And then there's a long neuron that then releases that norepinephrine at the effector site that we talked about previously. The adrenal system, a neuron releases acetylcholine directly onto those adrenal medullary cells, those neurons that forgot that they were neurons, and then they dump their neurotransmitter into the bloodstream. And that's the structure. And from the structure, you get function. And this is what those different things do. So we talked about Walter Cannon's fight or flight. So that's really the sympathetic nervous system getting you revved up. So what does noradrenaline, norepinephrine do in the body? Well, makes your blood vessels squeeze down to get blood pressure up, raises the heart rate. Some of the muscles that hold the eyelid open are innervated by noradrenergic neurons. So what happens if you damage those? Well, blood pressure isn't regulated appropriately. Eyelids droop. What if you knock out the sympathetic cholinergic system, that system that's responsible for sweating? Well, if you knock it out, you don't sweat. And that's one of the reasons that some people with autonomic disorders don't do so well in the heat. If you knock out the sympathetic adrenergic system, that's actually kind of hard to do. But adrenaline's other big job in the body is glucose regulation, so blood sugar regulation. We'll talk about fainting, but a lot of people are more likely to faint when they haven't eaten. That's adrenaline's fault. What does the parasympathetic nervous system do? Well, if the sympathetic nervous system is the part of the nervous system that gets you ready to fight or flee, well, the parasympathetic nervous system is more that rest and digest, or what has also been termed stuff you do behind closed doors. So stuff like peeing, pooping, sexual activity, all of that relies on the parasympathetic nervous system. Saliva production, tear production, that's all parasympathetic stuff. And of course, the enteric nervous system, what happens if you knock that out? Well, the gut's going to stop moving appropriately. And if the stomach doesn't empty, someone might feel full really early with eating. If the large intestine doesn't move appropriately, a person may get very constipated. All right, tell me questions about anatomy. And for now, just limit it to questions about anatomy. Any neuroanatomy questions? I thought that was going to be the response. So
I was just going to say, how do you find this stuff out?
Are you asking how do you find this out in an individual person, or how was this discovered? Yeah, so actually lots of really great stories about these early physiology researchers and the studies they would do, largely on animal studies. A lot of their studies involved taking tissue out of animals and then putting different chemicals onto those tissues to figure out what types of substances reacted or caused those tissues to react, and then what substances could be put on to block those reactions. So, and actually, if you go back and read the history of these early investigators, it's absolutely amazing what they did with the tools that they have to work with, or had the tools that they had to work with. And there was actually a lot of serendipity involved. For example, the early investigations on acetylcholine and the role of acetylcholine in its physiologic functions probably would have turned out negative had the laboratory in which they were done not been unheated. So acetylcholine actually breaks down pretty quickly, but because it was like cold in Europe and being done in an unheated laboratory, that's probably why those early studies were successful. So a lot of ingenuity, a lot of hard work, and some luck. Yeah. We'll talk about how you figure out these things in an individual person, but it's based on that framework that these early pioneers of the field laid. If you do download Dr. Goldstein's ebook, he actually goes into the history of a lot of these folks in a way that's very digestible and entertaining to read. It doesn't read like a textbook. Let's talk a little bit more. Let's not talk a little bit more about blood pressure reflexes. Let's talk about some individual disorders. I know that most of you are here because you or someone you care about has been diagnosed with or has had symptoms concerning for POTS, postural tachycardia syndrome, or postural orthostatic tachycardia syndrome. Actually a pretty common disease. It's in our autonomic disorders clinics, whether we're talking about the numbers in our military autonomic disorders clinic or my colleagues in civilian practice. This and fainting is most of what we see. And we're running maybe up to 1 out of 100 people in the United States, probably a little bit less than that, we don't know exactly, but pretty common. We talked about the diagnostic delay that is often experienced by people who are dealing with postural orthostatic tachycardia syndrome. And so what is that? What is this POTS? Well, it's really two things. One, an intolerance of standing up. That's the orthostatic intolerance. And two, an exaggerated orthostatic tachycardic response. So an exaggerated heart rate increase to standing up. That's all that POTS is. Lots of stuff can do that. So what I tell the residents and medical students is, once you diagnose POTS, the next question you have to ask is why? You might not find an answer, but you at least have to ask the question. How do we qualify an exaggerated heart rate increase with standing? We draw the cutoff at 30 beats per minute. Unless someone's under the age of 18, then it's 40 beats per minute. So I told you this is the most common thing that we see, postural tachycardia syndrome. About a third of the patients referred to our clinic. This is looking back at 215 consecutive patients. We actually see small fiber neuropathy in about 40% of our patients. So those post-ganglionic, so those second-order neurons that are taking the messages of the autonomic nervous system out to the various parts of the body, those are what we categorize as small fiber nerves because they're small diameter nerves. And in 40% of our patients, we identified evidence of a small fiber neuropathy. Now, those overlap. Some of these POTS patients had small fiber neuropathy. How many? Just over half. So just over half of our POTS patients in our clinic had evidence of a small fiber neuropathy. Now, probably some of these are due to some false positives in our testing because the testing that we have isn't perfectly specific. Either way, it's a pretty good section of the pie that individuals with postural tachycardia syndrome have evidence of a small fiber neuropathy. And numbers from other clinics vary, but in other clinics it is also a significant slice of the pie. So that goes back to the asking why. Why are these things happening? And we'll talk more about why. We'll save questions about POTS. Let me talk briefly, because I know there's a specific interest in this room about small fiber neuropathies. And we'll talk more in the evaluation section about how we evaluate small fiber neuropathies. But if we go back to our diagram of the peripheral nervous system, so one of the things that we see, if these neurons all get damaged, well, it's going to wipe out the entire autonomic nervous system. Interestingly, and we'll talk about one specific case later, the longer post-ganglionic neurons may be a little bit more susceptible to damage, or maybe slower to heal because they've got a longer course to traverse. And that's actually something we see in other forms of nerve damage. So people with nerve damage due to diabetes, it affects the longest nerves first. People with nerve damage due to chemotherapy, it affects the longest nerves first. And that may, in some conditions that damage the autonomic nerves, that may be a reason why the sympathetic nervous system symptoms tend to predominate. And there, we'll talk about at least, well, we'll see how much depth we go into in the fact that there is at least some evidence to support that theory. Okay. Let's talk about how we do testing. So going back to that question about what is the testing that we do in an individual person that's built on the foundation that those early physiology researchers laid for us. This is the best test. Talking to someone. Asking what's going on. And what I told a group of physicians this morning is, and these were more seasoned physicians, so I was able to say, as you guys know, 90% of your answer comes from the patient. So you got it. A big part of our job is targeted interviewing, right? Taking a history, and doing an exam. Lots of information can be gleaned just from examining the human body. And then comes the ancillary testing. So, how many of you have had a test looking something like this? Okay, a few hands go up. This is one example of a pretty standard autonomic screening test. We're going to go through the autonomic screening tests that are part of a typical battery. Why? Because I want to talk about, one, the physiology that's involved, and two, I want to talk about how we can test these things without fancy equipment. So one of the things that we do is we quantify the amount of sweat that someone can produce. This gives us a look at those sympathetic cholinergic neurons that we talked about. And most labs use the same setup. There are some labs that use some different techniques. And this gives us a good number, and actually a good number that can be tracked over time. But you don't have to be super fancy. There are lots of ways to test if someone sweats. So you can feel their socks. And this is like on a regular basis the grossest thing that I have to do as a neurologist. Feel people's sweaty socks, but it's helpful. Because if someone comes into my clinic in the mid-Atlantic and takes their boots off and their socks are dry, that's not normal. And I just got a lot of information by feeling their socks. You can look at the skin under magnification and see if there's little sweat droplets on the skin. You can drag a smooth metal object across the skin to see if it grabs normally, if there's a little bit of friction that skin that's producing sweat will have. People who are anhydrotic, not making sweat, that metal object, like a soup spoon, will slide right across the skin. So lots of things that can be done in a very simple manner. You guys don't have to do these. Your doctors have to know how to do these. But it's kind of cool to know about, right? You can feel your own socks. So we can test those parasympathetic responses. And one we do in the laboratory is by testing heart rate responses that are mediated by the parasympathetic nervous system. We test how the heart rate goes up and down with deep breathing. And so if someone breathes in deeply, the little blue curve here is the breathing in and out. The green curve is the heart rate. You can see how someone starts breathing deeply, heart rate goes up and down, up and down. With normal breathing, a normal person's heart rate goes up and down. When we breathe deeply, that gets exaggerated. And we can measure that difference and get an average difference and compare that average difference to age-matched norms and tell whether someone's parasympathetic reflexes are functioning, at least the heart rate part of those parasympathetic reflexes. You don't have to have fancy equipment to do this. You can take someone's pulse with your fingers. You don't need fancy equipment to breathe in and out deeply. So if someone has profound parasympathetic heart rate regulation failure, You can feel their pulse and have them breathe in and out. Their pulse will stay flat. Now, the one test that we do in our autonomic testing laboratory that does require some more special equipment is the Valsalva maneuver. So a Valsalva maneuver is when you like bear down and increase the pressure in your chest and abdomen. So it's something we do every day. Bend down to pick up a box, give a little grunt. If you haven't eaten enough fiber when you're on the toilet, Valsalva maneuver. That's what a Valsalva maneuver is. I saw some people nodding like, oh yeah. Sorry. That's a Valsalva maneuver. So we have people blow into a tube that gives a lot of resistance. And when that happens, because the pressure is increased in the chest and abdomen, the blood pressure actually drops. And we're looking, after that blood pressure drop, we're looking for a reflexive increase in blood pressure and a reflexive increase in heart rate. We're looking for that reflexive increase in blood pressure, and then after the person stops doing that Valsalva maneuver, blood is pumping into a reflexively constricted vasculature, and the blood pressure goes up higher than it was before. So there's an overshoot. For someone in whom those blood pressure reflexes are broken, it looks like this. There's no reflexive increase. There's no overshoot. In fact, it takes many seconds for this person's blood pressure to get back up to where it was before. So in this case, that signal about blood pressure, nothing's being done about it, either because it's not getting to the brainstem or the brainstem doesn't care or the signal's not getting out. In this case, the heart rate didn't change either, and that actually helps us know that, hey, this is a problem of information getting to the brainstem or a problem in the brainstem itself. So to look at these blood pressure responses, we do need beat-to-beat blood pressure measurement. All right. Oh, and then we do a tilt table test. And you can do a tilt table test just with a blood pressure cuff on. But you can also just have someone stand up. You don't need a table with a hydraulic motor on it. You can put a blood pressure cuff on someone and have them stand up. You don't need fancy equipment for this. Now, the fancy equipment, with the beat-to-beat blood pressure measurement, it does give we get a blood pressure with every beat of the heart. So we can hone in a little bit more precisely, and that's nice for the tilt table test. And those four things are kind of what we do as a standard autonomic testing battery in most labs. And that's kind of most clinical labs across the country. That's kind of what they do. There's a lot that's done outside of the standard autonomics lab that is important for the autonomic nervous system. My gastroenterology colleagues run gastric emptying and colonic motility studies. So how's the gut moving? My urology and urogynecology colleagues run urodynamic testing. Hey, how is the bladder doing in terms of appropriately squeezing down to empty itself? We can send someone home with a blood pressure cuff that cycles repeatedly throughout the day so we can get an idea of where blood pressure runs throughout the day. It can be helpful in some cases. That's outside of the autonomic testing lab. Any questions about testing? Okay. Question about testing.
Quick question on the Valsalva maneuver. What is the time lapse on that study when it does regain?
So on that one tracing specifically,
Yes.
how long? I don't remember what the x-axis is set at here. This from line to line here is either 13 or 15 seconds. So we have the patient perform the Valsalva maneuver for 13 to 15 seconds. And so if you look, hey, right there is at least 13 or 15 seconds, and come out here, they're still not back to normal. So this person's beyond 30 seconds.
Okay.
Profoundly abnormal. What's a normal pressure recovery time? Less than 4 seconds. Less than 4 seconds is normal.
In most, I don't even want to say disease, but in most situations there is a range of severe to minor. So if that was the case on this, this says failure, so I assume this is the worst case or one of the worst cases, but would you be able to tell if it was more of a minor case or if it was a case that kind of came in, you know what I'm saying, the body kind of is recovering?
Right. So we can't tell chronicity based on this test. Unless we did it multiple times over a period, we could tell if someone is recovering. But we do categorize these baroreflexes. If there is some failure, we categorize it as mild, moderate, or severe, depending on what parts of the blood pressure reflexes are disturbed. And they tend to be disturbed in order as people get more and more severe baroreflex failure. So baroreflex, pressure reflex, more Greek than we're throwing out there. So someone like this is severe. But yeah, we do grade it that way. Any other questions about testing?
Sometimes I have GI issues, and then some days I can wake up and be able to eat and feel fine. Will gastric testing show that, or how does that work?
Only if you do it. So I guess we probably taught. So because there are good days or bad days, will testing show that? Only if you do it on a bad day. Is it gonna, right? And good days and bad days happen. And we definitely bring people into the autonomics lab, and their testing's not that bad, and like, you know what, I was having a good day. Okay, you're having a good day. Maybe we'll bring you back and do it on another day. Maybe we just keep our fingers crossed for more good days. So that is one of the challenges in diagnostic yield. Yep. Let's go back in the blue shirt on question on testing.
Given the delay in diagnosis, who realistically should we look for doing these types of tests? Cardiologists, neurologists, or even more of a specialist?
Yeah, who should be diagnosing autonomic disorders? My answer would be everyone, right? And that's one of the challenges in diseases of the autonomic nervous system, is that they have manifestations throughout the body, right? So these are pan-organism diseases. Like, so if your sympathetic nervous system is messed up, you're talking about, you can get ptosis, you have blood pressure problems, you might have heart rate problems. If your parasympathetic nervous system is messed up, you have constipation, urinary problems, problems making spit. Who owns that? The cardiologist says, well, you got tachycardia, but your heart looks just fine. I don't know why you're fainting. Gastroenterologist says, hey, the tubes all look good. We scoped you, things look fine, but the gut's not moving correctly. Who owns? Look, gastroenterologists typically own that more. So who owns the autonomic nervous system? The answer is everybody. That's one of the challenges in medical education is that education is siloed. We talk about organ systems of disease, and then someone does their gastroenterology training. And to some extent, that's necessary. To become an expert in a field, you really do have to put on your blinders and hone in on something. But to practice clinical medicine, you have to take those blinders off. And this is a soapbox for me to get up to step onto in front of groups of physicians. Not so much you guys, but you can help carry the message that really everyone needs to own the autonomic nervous system because it's in every organ system in the body. So who needs to be thinking about it? Everyone. Who needs to be making these diagnoses? Well, definitely general practitioners need to be aware. Cardiologists, gastroenterologists, urologists need to be aware. Orthopedic surgeons, probably not so much, right? Probably not. So, yeah, good question, hard answer. We had another question on testing.
Speaking of the testing, like my daughter's due to have an endoscopy because of gastroenterology type of GI issues. Now, doing an endoscopy, will that actually show motility? You know, her doctor actually told us she has blinders on. She doesn't want to know anything else that she has going on. So.
Okay. Doing an endoscopy does not give you any analysis of motility of the GI system.
Okay.
Yeah, it's a picture. Yeah. We had another question.
Would a specialist on dysautonomia that I'm going to see, will he be able to test me for mostly everything? And then I go to a GI doctor if I think I have a lot of these symptoms? He specializes in this. Doctor
Yeah.
specializes.
So it depends. All labs and all autonomic clinics are a little bit different. Most clinical laboratories are going to be running a pretty similar battery. Definitely, there are clinicians who care for a lot of people with autonomic disorders that don't have a standard autonomic testing laboratory, and that's okay.
This guy's been suggested many times.
Yeah.
He's in Clearwater, so.
Okay. So yeah, without knowing the details of his setup.
Yeah.
But yeah, and again, so much information is gleaned from talking to someone and doing bedside
I've
stuff.
seen him.
Next time we're gonna have to do either two microphones or two Ms. Walshes.
My daughter became aware of the gastric emptying and motility issues before she was diagnosed with POTS. So is that normal? I mean, is that the normal progression?
So the question was, your daughter had gastric motility problems before having other problems more consistent with POTS. Is that normal? And you probably, well, no, it's not normal because that's not normal. But is that pattern? Not necessarily, though that happens sometimes. Sometimes people will start with GI symptoms, then develop other symptoms. Sometimes it's the reverse. Sometimes people with POTS never develop GI symptoms. Sometimes people have profound GI symptoms of dysautonomia without orthostatic intolerance. So everyone's different in that regards. Yeah. Question in the back?
I have a question regarding what Morgan asked. Initially, if you do all the testing and everything comes back negative, but yet the doctor still diagnoses you with POTS, is that normal? But you still, like, she's still faint, she has all the symptoms, but every time she gets diagnosed, like you said earlier, it's all been on, I mean, and any time they run the test, like you said earlier, it's all on good days.
So the question is, if every time you run the tests, the physiologic data gathered looks totally normal, is it reasonable to still call that POTS? Well, I'd have to say no. Because if there's no demonstration of exaggerated orthostatic tachycardia, it's by definition not POTS. There's no orthostatic tachycardia. Doesn't answer what it is, but...
But like at home when we do the blood pressure and the heart rate and all that, of course, it's not normal.
Oh. So I mean, if
Yeah,
you've had times where there's been a demonstration of exaggerated orthostatic tachycardia, sure.
Okay.
The box is checked. You can then take that label. Then you have to ask why. But, yeah.
Thank you.
Okay. So let's talk about a brief selection of common disorders. So let's talk about when blood pressure falls when people stand up. Orthostatic hypotension. So this is a tracing from one of our patients. Let's zoom in there. You can see what. So here are blood pressures at different times. You can see that lying down, this person had a systolic blood pressure of 153 millimeters of mercury. Diastolic pressure, the lower number, just below 58. Tilted the person up. Blood pressure, first minute dropped by just over 50 millimeters of mercury systolic. Not normal. And we zoom in, here's the tracing, drops off. Person recovered a little bit and made it out all the way to just past 10 minutes. Why? Well, why might blood pressure not be kept up appropriately? It could be because that reflex, that blood pressure reflex is broken. Either because that blood pressure information is not getting to the brain, or the brain stem doesn't care about the blood pressure, or the sympathetic nerves taking the information out to the blood vessels, telling them to squeeze down, aren't working right, or maybe that signal from the neurons to the receptors on the blood vessels is not being communicated appropriately. Anywhere in that loop, you're going to have orthostatic hypotension. And if it's because that loop is broken, that's what we call neurogenic orthostatic hypotension, because that nervous system reflex is broken. Other stuff can cause an inappropriate drop in blood pressure with standing. So if I don't drink water for a couple of days, maybe one day hanging out in the Florida sun, my blood volume is going to decrease. That's going to cause orthostatic hypotension. Maybe my adrenal cortex isn't working. Maybe my body's making weird substances that make my blood vessels dilate. That'll drop blood pressure. Those are more rare, but we occasionally find that. This is the one that is not so occasional. And we see this more often in a population of more advanced years than most of you sitting in this room. So people get put on a blood pressure medication because they have some hypertension. And then we'll say it's a man who gets put on prostate medicine for some prostatic hypertrophy. That also lowers the blood pressure. Then maybe he gets put on something to help him sleep better. And many of those medicines also lower the blood pressure. So all of a sudden you got a guy who's coming in complaining of being really dizzy and his blood pressure is dropping. Well, it's not because there's something wrong with his body other than too many prescriptions or not the right prescriptions in combination. So that's one to be aware of. Probably doesn't apply so much to people in this room. I know it applies to at least one of you in this room. Fainting. So we talked briefly about fainting. Syncope is the Greek word. Syncope, just Greek word for fainting. Well, why do people faint? So to put it simply, fainting is not enough blood flow getting to the brain for a brief period of time. So it's reversible. If it's not reversible, it's called dead. Right? Do people die from fainting? So not usually, right? Because they fall down and blood flow gets back to the brain. But if there's a problem getting blood flow to the brain and people don't fall down, they can die. And we've had cases of that. So if someone faints, they need to lie down. They need to be allowed to lie down or fall down. It's better if you can help them lie down. The other reason that people might die from fainting is if the problem causing the fainting is a heart problem, where the pump temporarily stops working and then starts again. Either because it stops, or it starts going really fast, starts going really slow, and then starts again. The worry is that sometime it might not start again. And when it's a heart problem causing the fainting, we call it cardiogenic syncope. And that's the really dangerous one. That's the one where we have to have you hooked up to monitoring while we capture a spell to say, hey, was this coming from the heart or not? And if we look at your heart when you have a spell and it's electrically normal, done. It's not coming from the heart if the heart's electrically normal during a spell. Assuming that the heart is structurally normal as well. Syncope, fainting, can happen because of orthostatic hypotension. We talked about the things that can cause that. Syncope, most often, though, is due to what we categorize as reflex syncope. The most common of which is the classic faint, vasovagal syncope. And many of you in this room have experienced this. Many people have experienced this. So that common faint where you're feeling clammy, sweaty, maybe nauseous. People look at you and you look pale. That's a classic faint, what we call vasovagal syncope. Gets really confusing because we've used a lot of other terms for it. Terms like neurocardiogenic syncope, neurally mediated syncope, even the term autonomically mediated syncope. All those terms have been thrown out, all referring to the same thing, the classic faint, vasovagal syncope. Vasovagal syncope is probably the preferred term right now. There are other situational syncopes. There are people who are particularly sensitive to pressure on the part of the carotid artery that senses blood pressure, and having pressure on there makes them drop their blood pressure and pass out really easily. And there are other more rare things that can cause fainting. Sidebar, how do we define orthostatic hypotension? You have to have a drop in systolic blood pressure of at least 20 millimeters of mercury, or a drop in diastolic blood pressure of at least 10 millimeters of mercury within 3 minutes of standing up or being tilted up. So those are the definitions. All right, we talked about POTS. We went through that earlier. Let's talk about evaluation. Let me take some more questions. So how do we beyond the taking a history, which is absolutely essential, doing an appropriate physical exam, which is absolutely essential. We talked about the testing of the autonomic nervous system that we can do. What do we do to actually try to unravel the why of why these disorders are happening? And the answer is it depends. It depends on the disorder that we're working with. But since POTS is most common, let's talk about that. The why of POTS gets complicated. It gets really complicated. This slide's supposed to be overwhelming. It's intentionally unclear. There are lots of things that we know are seen in people with POTS. Lots of things that we think may be contributing to POTS. And then there are lots of ways that all of these things interact with one another. And as you see arrows going in different directions, you can see how in a lot of places there's a role for what in systems design we would call positive feedback loops. So when we talk about feedback loops, you can think of the thermostat at home. So your air conditioner, you set it at, this room probably sets it at 66 degrees Fahrenheit, right? Set your thermometer at 66 degrees Fahrenheit, or the thermostat at 66 degrees Fahrenheit. As soon as it gets up to 67, the thermostat says, oh, there's a difference here. I need to turn the air conditioner on. Click, air conditioner goes on, cools the room down, temperature drops back to 66 degrees Fahrenheit, thermostat turns off. That's a negative feedback loop. So that the response that's triggered turns off the stimulus. Positive feedback loops, something different happens. The response turns on the stimulus. And when that happens, really powerful stuff occurs. So nuclear reactions, that's a positive feedback loop, where it's a feed-forward mechanism. Childbirth is a positive feedback loop, where the activity in the uterus makes more activity in the uterus. It's a feed-forward mechanism. The common faint is actually a positive feedback loop. It's a feed-forward mechanism. And from pathogenic mechanisms, you can see in a diagram like this, like, hey, there are lots of places where feed-forward mechanisms can occur, contributing to the symptomatology of POTS. So in all of this mess, what actually becomes really important? Well, checking vital signs, that's important. We talked about the importance of ruling out an underlying heart condition. That's really important. Fortunately, it's actually pretty easy. And you can determine pretty quickly whether or not the term is, you can determine pretty easily whether or not the heart is structurally and electrically normal. Most of the time. Now, one really important one, for people who don't tolerate standing up, we've learned that it's really important to check the cortisol. So we've talked about the adrenal glands, and we talked about the adrenal medulla. I mentioned the adrenal cortical cells briefly. So cortisol comes from the adrenal cortical cells. So actually two parts to the adrenal glands. There's the sympathetic adrenergic part, the adrenal medulla, the neurons that forgot that they were neurons. But wrapped around those are some actual endocrine cells, the ones that produce cortisol. And if those fail, you get fatigue, you get problems keeping your blood pressure up. And as we went through our series of 215 patients referred to our clinic, just over 2% of them. It's actually almost every 50th patient is actually like marching out, almost predictably, by chance, not by anything else. Just over 2% of patients had adrenal cortical failure. And that can come because of problems in the pituitary gland or problems in the adrenal glands themselves. So that's important to check. Now, I'll tell you that those patients, though they were referred, some of them were referred for POTS, when we actually tested them, those that were referred for POTS actually had orthostatic hypotension. Their blood pressure dropped, so by definition, they didn't have POTS. They had orthostatic hypotension. And why? Because they had adrenal failure. So that's important. The other thing that I think is important in people with POTS goes back to the small fiber neuropathy question. How many patients with POTS have small fiber neuropathies? And so it's important to screen for those. And if you find it, again, ask why. You might not find the answer. And actually with small fiber neuropathies, you're probably not going to find the answer. We know that more than half the time, when someone has a small fiber neuropathy, we don't find a specific reason why. And there are probably a variety of reasons why that happens. Perhaps one of the reasons is that in many cases, there's some disease process in which those small fiber nerves are damaged. That process runs its course and goes away, and then people are left with what they're left with. And that's often a pattern that we see, and we're just left with something happened. And the nerves got damaged, and now we're managing symptoms and monitoring for any changes. When we do see people with small fiber neuropathies, you have to think about diabetes and alcohol use, because those are the two most common causes of small fiber neuropathies. But the other one that we see a lot in the autonomic disorders referral clinics is autoimmune diseases of the nervous system. So the case that I referred to was actually published by my mentor, Dr. Goldstein, a young woman who developed global autonomic dysfunction that was pretty profound in association with arthritis. And she was investigated in depth in the clinical neurocardiology section that demonstrated a profound loss of her postganglionic autonomic nerve functions. And she's actually restudied a year and a half later and found that some of those nerves were healing. So the nervous system heals. It heals slowly, and it heals stupidly. Can you really make that an adverb? I just did. I actually use that term a lot in peripheral nerve injuries and why? Because often nerves don't heal completely, and when they resprout and regrow, they often miss target a little bit. So hence nerves heal, but they heal stupidly. So this was a pretty profound case of an acute autoimmune autonomic neuropathy. And this was, while on the more extreme side, this was actually a story that we see not all that uncommonly in our clinics. So when Dave Goldstein, my mentor, was really excited about this, and rightfully so, because very important and in-depth data was gathered, investigations that aren't done outside of the National Institutes of Health, I told him, Dave, this is a story we see all the time. Like, this is a very common story where something happened, the nerves took a hit, there's some partial recovery, and then we're dealing with symptoms. So when we looked at our POTS patients with small fiber neuropathy, 30% of those, so that's 11 of these 37, so about 30% of our POTS plus small fiber neuropathy patients had a possible or probable autoimmune disease. And these ran the gamut of different autoimmune diseases. When we looked at our POTS patients without small fiber neuropathy, only 6.5% of them had evidence of a probable or possible autoimmune disorder. So that tells us that, hey, in people with neuropathic POTS, being attentive to the possibility of an autoimmune condition is particularly important. And here's I mentioned that they ran the gamut from a post-infectious cause that we saw in multiple individuals to more common autoimmune disorders like lupus. When we looked at our small fiber neuropathy patients as a whole, that is not just the POTS patients, but as a whole, 29% of them had possible or probable autoimmune diseases. And these were these were actually the 5 most common and somewhat reflective of other groups' experiences. So actually those were our numbers right there of those 25. I threw up this reference there more for the clinicians because there's an article that actually has great lists for causes of small fiber neuropathies that I often refer back to and refer my residents back to. The autoimmune story in POTS is still very much evolving. While we've recognized for years now that there are higher rates of autoimmune disorders in people with POTS, we're getting more and more information about specific autoantibodies that are in the bodies of people with POTS. And just marching through the studies in the really the past 5-6 years, there's more and more information, and we're not going to talk about each and every one of those individual studies or autoantibodies, but again, recognizing that this is very much in evolution. So let's break for a moment and talk about other comorbid conditions in POTS. Because as we talk about the workup for the why of POTS, we talk about screening for adrenal failure, screening for small fiber neuropathies. There are other things that overlap with POTS, and a big one is the joint hypermobility syndrome. So Ehlers-Danlos syndrome, EDS type 3, joint hypermobility. People with joint hypermobility syndrome seem to have increased rates of POTS. People with POTS seem to have increased rates of joint hypermobility. Why? Well, easiest possible mechanism is that when you've got joint hypermobility, because your connective tissues are stretchy and loose, well, you're going to pool more blood in your venous system. And if more blood is pooling when you stand up, not as much blood is getting returned to your heart, not as much blood gets returned to the heart, therefore there's not as much cardiac output. Therefore, you don't feel as well, and your heart rate has to speed up to keep up with the demands of your brain. There are other theoretical mechanisms for why there might be increased rates. But then there are other things that can go on in people with joint hypermobility that can contribute to or mimic the symptoms of POTS. So we recognize that people with joint hypermobility have increased rates of craniocervical instability, where the connection of the head to the neck is a little unstable. And if you get instability there, well, remember what runs right through there is the top of the spinal cord. Kind of important to keep that intact. And if there's instability going on that's putting pressure on that, that can affect possibly the lower part of the brainstem. That can affect those communications between the brainstem and the spinal cord and cause autonomic and/or other neurologic symptoms. People with joint hypermobility do have increased rates of tethered cord, where the bottom of the spinal cord is actually connected to the bottom of the spinal column. So actually our spinal column, if you didn't notice, the spinal column grows more than the spinal cord, and the spinal cord actually ends at the first or second lumbar level. If someone's spinal cord is attached to the bottom of their spinal column, this particularly happens as children grow, they can get symptoms that affect their legs and affect urinary control, control of stool regulation. And sometimes we see that not happening in children, but presenting in adulthood. People with joint hypermobility seem to have increased rates of intracranial hypotension, where the pressure of the fluid that surrounds the brain and kind of keeps it buoyed up and cushioned is decreased. And so the brain kind of sags down. That can cause headaches, especially orthostatic headaches, headaches that come on with standing up. Intracranial hypotension, if there's enough brain sag, that may cause problems with brain stem associated symptoms. It may be that people with joint hypermobility have increased rates of compression of their celiac artery or celiac plexus, the network of nerves that supplies the gut, by the arcuate ligament. So the arcuate ligament is the ligament at the top of the diaphragm. The aorta has to pass from the chest into the abdomen, and the arcuate ligament is the connective tissue structure around that passage through the diaphragm. And there may be more people with joint hypermobility that have compression of the artery or the nerve plexus right at that site. Predominantly, that's going to present with abdominal pain, so slightly different clinical picture. But these are things that we see we see at higher rates in people with symptoms referable to the autonomic nervous system. So these are things that we have to think about in our clinics. This is also these are also topics that are in evolution, because how aggressive to be in looking for these, and the best studies to do for some of these to diagnose them, that question is not totally answered. There's things that I think about when I'm lying awake at night. Actually, to be honest, I don't lie awake at night. My head hits the pillow and I'm out like that. Sorry if you don't have that. Thank you. But I do think about this a lot, actually. Okay. Let's talk about treatment, and then let's just do questions, okay? So how do we treat? So we're going to talk about orthostatic hypotension, then I'm going to talk about POTS. A lot of overlap here. So how do we take care of blood pressure dropping when people stand up? Well, the first thing to do is stuff that we can do without medicine. So first is sit down or lie down before you fall down. That's a good rule in life. I'll say it again. Sit down or lie down before you fall down. So if you faint, you know what? Sit down or lie down before you fall down. And if it's the middle of the grocery store, that's okay. It is better to lie down in the potato chip aisle. And I only say potato chips. I know you're trying to get increased salt. No one else should eat potato chips. Lie down in the grocery store or the shopping mall. Because if you lie down and people are like, hey, are you okay? Yeah, I'm fine. I just need a minute. It's going to be a lot better than falling down, because you know they're going to call the ambulance, right? And then you're going to feel even worse afterward. So sit down or lie down before you fall down. Other safety precautions can often become important, especially in people with neurogenic orthostatic hypotension who don't get as clear a warning as many other people with fainting. People who drop their blood pressure really quickly, they might have to take the furniture away from around their bed. They might have to get a lower bed. They might have to be putting grab bars in the bathroom. They might have to have someone go to the bathroom with them. Because guess what? If you fall and crack your skull open or fall and break a hip, that can be game over for a lot of my patients. So safety is really, really important. A lot of people with orthostatic hypotension get a lot worse after they eat. So I have to tell my patients, don't eat big meals. Don't eat a huge carbohydrate load. Eat small, frequent meals. So compression garments. And those of you that aren't new to this game have already read about these and probably tried these. Compression garments are fabulous in Florida, especially in the summer. Waist high. So the theory is you put these on, they compress your legs, pelvis, lower abdomen. That pushes blood back up into the heart, increasing cardiac venous return, increases cardiac output, increases blood pressure and cerebral perfusion. Compression garments work. We know they work. The higher, the better. But I know they're a pain to deal with, especially when you live in the Southeast. And so if you're like, look, yeah, doc, I know they work, but it just ain't working for me, I get it. Thanks for trying. Try something else. For people with orthostatic hypotension, actually putting the bed on an incline is very helpful. It reduces the loss of blood volume through the kidneys into the urine at night. And one thing that's really cool that can be taken advantage of, not just in people who have orthostatic hypertension, but in other people who faint, is the osmopressor response, where if you drink half a liter of fluid, 2 cups of water, if you drink 2 cups of water, plain water, your blood pressure actually goes up about 15 millimeters of mercury. And it does that for a little over 30 minutes. Very predictably. So that's something that you can really take advantage of if you know, like, hey, I've got to stand up for this meeting, or hey, I'm going grocery shopping. I need to get my blood pressure up a little bit more. Drink half a liter of water. And we're not talking sipping. You actually have to drink it, like, over a few minutes. Keep sipping throughout the day, like you are all doing a good job of. And then in terms of orthostatic hypotension, we can use medicines. And some of you will recognize these medicines because some of you have been on them. And we use a lot of these in POTS. Really 3 things that we focus on, 2 main things, and then the other category. So volume expansion, that is getting the blood volume up. Mainly we use fludrocortisone, a medicine that helps the kidneys hang on to more salt and therefore hang on to more sodium and therefore hang on to more water. There are other medicines that we can use for volume expansion, but that's the mainstay. We use medicines to make the blood vessels squeeze down. And we'll talk more about some of these in a minute. And then other medicines that can be used as adjuncts or alternatives in orthostatic hypertension. So what about POTS? We talked about hydration, stay hydrated. Who in here has not been told to consume more salt? Has anyone not been told that? Okay, let's check. Oh, how much salt? How much salt? It's a good question that I don't feel has a good answer. Probably, as a blanket recommendation, an extra 3 teaspoons a day. That's a lot of salt. That's a lot of salt. One piece of advice that I heard from a colleague that she tells her patients that I kind of stole from her, because I thought that's a good way to do that. She tells her patients, and now I tell my patients, if you got to get 3 teaspoons of salt in a day, put those teaspoons of salt into a baggie or some other container, and throughout the day, sprinkle it on your food, eat it. And at the end of the day, if you have salt left in your container, guess what you get to do? Open up. Probably tastes better to spread it out. The question is it better to spread it out that way? We have in terms of efficacy, no idea. No idea. And who needs more salt? Is there a way that we can predict who actually would benefit from salt, increased salt intake? And even beyond that, be able to tell them how much extra salt? We have ideas for maybe how we might do that, but we don't know. We don't know how to tailor that advice. That's probably something that we should be able to figure out in 2018, but we haven't yet. There's a research project.
Nice.
Is there an amount? Yeah. So because when you lie down at night, your kidneys are getting extra blood perfusion, you lose blood volume because it's coming out in your urine. Is there any type of guide for how much increased liquid you should consume at night? No idea. I can tell you how much you shouldn't drink. You shouldn't drink so much that you're having to wake up to pee all night long and it's disturbing your sleep. Yeah, if you're peeing all night because you're drinking so much, you can cut back. Yeah, don't sacrifice your sleep because you're visiting the toilet. That's no, I don't need research data to help me with that one. Unlike the how much salt to take in and lack of data there, we actually do have really good data regarding exercise and POTS. I want to re-emphasize the fact that POTS is a heterogeneous condition. Lots of things can lead to orthostatic intolerance and an exaggerated orthostatic tachycardic response. But we know as a whole, when we look at the physiology of people with POTS, they have decreased blood volume and they have decreased cardiac output, consistent with physical deconditioning. And if people with POTS are put through a prolonged, graded exercise regimen, their symptoms get better, and those markers of deconditioning get better. Blood volume increases, cardiac function increases. Exercise is really important. How do you do exercise? Especially if you can't tolerate standing up, how are you going to go to the gym and hit the treadmill? Oh, there's the physiologic changes slide. How do you actually do exercise? Well, it was Ben Levine's group down in Dallas that really gave us a better idea of how to do this, where they walked patients through a progressive regimen that began with recumbent exercises. So exercises sitting down or lying down, and then gradually increasing the intensity and getting people into upright exercises. 3-month program. So recumbent exercises like a rowing machine, recumbent bicycle. Probably not as cool as this one. They actually didn't do aquatherapy in their. They mentioned something about aquatherapy in their study, but it's not a mainstay of the protocol. But aquatherapies can be very helpful. And they gave us good data on that. They had a 24% dropout rate. Exercise is hard. Being consistent in exercise is hard. Being consistent in exercise is hard when you aren't dealing with a health condition, right? And I know every January 2nd when I go to the gym, it's going to be packed. I know I only have to wait 3 weeks, and it won't be packed again. Being consistent in good habits, particularly exercise, is hard. But it makes a difference. Whether you're dealing with a physiologic abnormality or you're not, physical exercise makes a big difference. And in everyone who did the training, all of them had a better quality of life. And that was in their initial data with a much smaller group. Subsequent study spread across multiple centers, much larger group. They were eating their 2 to 3 teaspoons of salt. In the real world, more than half dropped out. Gym's empty on February 1st, right? But of those who completed the program, 71% no longer met diagnostic criteria for POTS. 7 out of 10 got better to the point. Physiology looks normal within our ability to test at bedside now. And looking a year later, that benefit was still there. And actually, from what I remember, they didn't even look to see, are these patients still exercising or not? This is just looking down the road. All right. So hydration, salt intake, exercise, and then medicines. So what medicines do we use for POTS? So we already talked about volume expansion. That's often helpful. Midodrine, little bit of helping blood vessels squeeze down. That's often helpful. Other medicines that help vessels squeeze down are often helpful. And we can lump these under the category of sympathomimetics, things that make primarily norepinephrine more available in the body. Things like methylphenidate, which many people know as Ritalin or Concerta. Things like atomoxetine, Strattera, amphetamines. And we have data from case series to support the use of those different medicines. No head-to-head comparisons. We don't know how well they work compared to one another. So there's definitely trial and error in all of these. One of the big benefit from the sympathomimetics is that they don't just work in the periphery. So midodrine just works in the peripheral nervous system. Sympathomimetics get into the brain and make noradrenaline more available in the brain. And that seems to be really helpful for dealing with brain fog. So being on a medicine that helps noradrenaline be more available in the brain and in the periphery tends to be particularly helpful in patients with POTS and orthostatic intolerance generally. We often use pyridostigmine. So pyridostigmine blocks the breakdown of acetylcholine. So remember the picture that we had of the first order neurons communicating with the second order neurons? We noted that acetylcholine is how those neurons talk to each other. Pyridostigmine makes that upstream neuron communicating with the downstream neuron more effective. It also keeps acetylcholine around in the parasympathetic nervous system and in the gut. So pyridostigmine is especially helpful in people with POTS and constipation. So if you got constipation and POTS, this is something that I'm definitely going to be thinking about offering. And it's really well tolerated. And then a variety of other agents that we can turn to. All right. I think we hit all of those. Before I take questions, let's talk about where you can learn more. Well, you're here. So I know you're at least somewhat plugged into resources. The Dysautonomia Project website has resources. Dysautonomia International has resources. I mentioned Dr. Goldstein's illustrations and his ebook that you can download online. The journal Autonomic Neuroscience actually has an issue coming out dedicated to POTS. I think it's going to be pretty good. I've actually not read all of the articles that are in it. They are available online. The print edition isn't out yet, but they are available online. And I know one of the questions that I have here, I'm going to refer back to one of those papers specifically, because I think it's actually it's one of those papers that's kind of I think probably going to be a top of the pile paper for me that I go, here, resident, read this. Oh, here, Glenn, read this and review it, because it's helpful. So, resources. Okay. The book, the Dysautonomia Project book, was mentioned earlier. So this is what I want to do. We'll alternate audience question, and then I have some questions that were sent in ahead of time that I'll try to give an answer to. Good idea. Yep.
As far as overheating, do you know of any triggers for that or how to control it?
Ooh, so dealing with heat intolerance in POTS and dysautonomia generally. It's hard, and so two things to think about in terms of overheating. One is there a lack of sweating? And if there's a lack of sweating, well then, okay, how can I replace sweating? I can't mist the body, right? You spray the body down. Cool the body directly, and there are lots of ways to have wearable cooling devices, from low-tech ice pack around the back of the neck to more high-tech vests with their own refrigerant system. That I like tech, but that seems a little bit burdensome, unless it's what you need to be able to go out and function. The other thing to think about is the other way. So our body regulates blood pressure by sweating, but also by dilating the blood vessels in the skin. And if you're dilating blood vessels in the skin, blood has to come from somewhere, and if it's filling up the blood vessels in the skin, it's not going to the brain. And that's where a lot of the symptoms in a lot of people with orthostatic intolerance that gets worse in the heat comes from. So what can you do? Well, boost the blood volume through those mechanisms that we talked about. Not just the medicines, not just the consuming it by mouth, but also by physical exercise. That increases the blood volume. And be safe. Make sure you're being, be safe. Okay, I'm going to come over here for one question, then we'll go back. All right, so question. After having experienced 2 autonomic labs, what would you say are the main lessons you have learned? The main lessons are there are gremlins in every system. Like trying to get the kinks worked out is always a process. And at this point, I've learned, yep, there are going to be things. And so coming back up to Walter Reed, we brought in some new equipment, some upgraded capacities, new kinks to work out. You know what? That's just par for the course. And I guess that's, maybe I've gotten a little bit wiser over the years as I've become a little bit more patient. But along with that, there are always ways to improve the system. And that's the other thing, is that, and this is more philosophical than autonomic disorder specific, there are always ways to make things better. And it's important not to become complacent with good enough. If there's a way that we need to change things to do better in any system, we need to look at the cost of implementing those changes, but we need to seek to make our systems better so that life is better. That sounded deep.
You had
Let's
a
go
question,
back.
right? Okay, I think I saw your hand up next.
Hi. I had a bilateral adrenalectomy, and I have to depend on fluorocortisol for this. Even though my numbers are normal, I'm wondering if it could be not enough.
Okay, so the question was, after a bilateral adrenalectomy, if the adrenal glands aren't there, someone's going to have replacement of the mineralocorticoid function. And even if the numbers are good on fludrocortisone, the question was, I'm wondering if that's not enough.
I do have POTS symptoms.
Yeah.
I have symptoms of a lot of this.
And that's a tough question. I'd have to say, look, that is a question for your endocrinologist. Generally, though, the things as a neurologist that I would think about would be trying hydrocortisone instead of fludrocortisone.
I do take hydrocortisone.
And oh, that's good. And then I'd think about trying different doses. But that's a very important endocrinology question. Yeah. Oh, I guess let's go here, and then I'll do another question from the paper.
Where's that coming next? Right here.
I just wondered, when you talked about small fiber neuropathy, is that something that a POTS patient should be tested for? Is it just another piece to the puzzle, or not?
Yeah. So I think people with POTS should be screened, at least clinically, for small fiber neuropathies. To go a little more in depth, so those small diameter unmyelinated or lightly myelinated neurons really do two main things. One, they control the autonomic functions. Two, they're responsible for some of our sensory modalities. So those are the sensory fibers that bring information about temperature and about pain, pinprick type sensation back into our central nervous system. And so when I've got someone in my autonomic disorders clinic, I've got to think about small fiber neuropathy. So I'm going to check temperature sensation in their skin. I'm going to check pinprick in their skin. And then I'm going to look clinically for other evidence of a small fiber neuropathy. Does everyone need a pseudomotor reflex test to look a little more specifically at those nerves? I don't know that I could say that definitively. It's helpful. Does everyone need a skin biopsy to look at those nerves under a microscope? I think not. Although we do lots of skin biopsies in people when we have a suspicion for a small fiber neuropathy. So I think that question has to be at least addressed, and those two tests are the most common tests that we do to confirm a small fiber neuropathy, and also actually give us numbers in terms of severity that aren't perfectly reproducible over time, but we can track over time. Yeah. Let me go here and then we'll. As an autonomic disorder specialist, what words of wisdom can you offer to community-based doctors that are just now starting to see and treat dysautonomia patients? So answer is, and probably not completely relevant to you all since you're not physicians, but again, you are part of carrying the message forward. I think two things that I would say. One, that history, taking a history thing that we talked about. Talk to your patient and listen to your patient. Ask the questions that are important to figure out where in the autonomic nervous system a problem may be, or where in the body a problem may be, outside of the nervous system. Ask the right questions, and then listen. And then second, don't be afraid to reach out for help. Whether it's going back to a textbook, calling a colleague with more experience, emailing a colleague with more experience, that's absolutely something that a clinician can and should do. I can tell you the clinicians that I admire, the doctors that I admire, like hey, I want to be like that when I grow up. They're senior guys with great experience. They still reach out to their colleagues and ask questions. Hey, I'm dealing with a difficult case. Can I run this by you? Hey, can I get your thoughts on this? What would you do in this situation? Good people ask for help. Let's go back for another question.
Anesthesia, it's my understanding that it temporarily shuts off your nervous system. And I noticed when I was going under multiple scopes, under multiple anesthesia last year, my symptoms seemed to be worse. I'm wondering if the anesthesia is related to the worsening of my symptoms.
Yeah. So were the anesthetic agents used in the performance of your procedures, did that contribute to the worsening of your symptoms after your procedures? The answer is there's a good chance that they were. So a lot of the anesthetic agents decrease blood vessel tone. And so there's one reason why that could have happened. Having invasive medical procedures does bump up the inflammatory state of the body. And so there's another potential mechanism for by which symptoms could be worse after a medical procedure. So could be the anesthetic agents, could be the procedure itself. Yeah. In most cases, it is probably temporary. We got. Let's do some more audience questions.
On my tilt table, I had the specialist. He diagnosed me with POTS and hyperadrenergic POTS. And also I have another doctor that says I don't have POTS because I also had, with the tachycardic, I also had hypotension during the tilt table. And he's saying I don't have it, so now I'm confused.
Yeah, so the question is, On one testing, there was an exaggerated orthostatic tachycardic response with normal blood pressure. Other testing, increased heart rate, but blood pressure dropped and there was orthostatic hypotension. I'd say based on that testing, there's not POTS, there's orthostatic hypotension. We do see people who evolve that might start out with POTS and then have a worsening of their condition and develop orthostatic hypertension, that happens, and I can tell you when that happens, I go, okay, what's going on in my patient's body? They're getting worse. Like, first their heart rate went up, but their blood pressure was okay. Now they're getting worse. And I'm actually going through that with the patient right now, and I'm going, all right, why? We thought you were stable. Physiologically, you're getting worse. We need to have a heightened level of suspicion for your autonomic neuropathy. Is it getting worse? Is a guy with an autonomic neuropathy? And we actually do see the reverse too. We see people with orthostatic hypotension of various causes that with treatment gets better, and they evolve into not having orthostatic hypotension and sometimes having just more of a POTS presentation. So things do change, and I think that the label is less important than the physiologic and pathophysiologic implications. So, okay, why did it change? What's happening?
Now, can I ask another question?
Sure.
Could the tachycardia be POTS and then the other disease processes cause the hypotension? Because it was only one test. They've only had one test, and it did both. I had the tachycardic and the hypotension.
So it's I'm not sure what your testing showed.
Mm-hmm.
I would ask, so in a single tilt table test, if an individual has POTS and if an individual has an exaggerated orthostatic tachycardic response and orthostatic hypotension, it's not POTS. Now, people with POTS have increased rates of fainting. And when you faint, your blood pressure drops.
I was almost fainted.
So it is not uncommon to have an exaggerated orthostatic tachycardic response. Blood pressure is doing okay. And then after 10, 20, 30 minutes of tilt, blood pressure then drops off a cliff. And usually then heart rate drops off a cliff. That's vasovagal syncope. And that should not be diagnosed as orthostatic hypotension. It's a faint. So the timing and the pattern does matter. And a faint is not necessarily orthostatic hypotension.
Awesome.
Yeah.
Thank you.
Yeah, let's go back here.
Hi, my question is similar to hers.
Sorry, what?
My question is similar to hers. I have hyperadrenergic POTS, where I test positive in the doctor's office with a poor man's tilt table. But when I go to the hospital and have the official tilt table test, where I can't eat after midnight, I test negative. And so my POTS episodes always come, it seems, after I eat. So therefore, not being able to eat before my tilt table test made my test negative. But anytime I get a poor man's and I was able to eat a few hours before, it's always positive. So I'm thinking, mast cell activation syndrome is common in people with POTS. And so what would you recommend, or do you see the way that they do the tilt table testing change, where people maybe go in after having fasted and then they're given something to eat and then see, if the POTS, it comes into full effect after they eat something?
So in terms of changing, of doing a testing protocol with or without eating, in a standardized form, I don't know that I'd make that standard, but we do variations of our testing for a given patient. But I think you've already found the answer. I think you found when your physiologic measures change, and I don't know that more testing with. I think you've already answered the question that If you eat, you're going to have a positive test. If you don't eat, you're not going to have a positive test. But then I think you have to ask, okay, then what do you do with that information?
Exactly.
What do you do with that information? I think it depends on, it would depend on why your symptoms are getting worse with eating. Is it due to increased blood flow to the gut? Is it due to something you're eating triggering mast cell release?
Well, what I'm finding is that I started the Ehlers-Danlos syndrome support group for Florida several years ago, and we also discussed POTS and mast cell.
Yeah.
Many of the patients have the symptoms of POTS and of mast cell, but they don't realize it until you go down the spiel of all the symptoms. And then when you have them just try at home and do the poor man's tilt table test just to see if there's a rise in their pulse, they do have a rise in pulse. But when they go, most of them, when they go into the hospital and they have the actual tilt table, it's always negative, but it'll be positive in the doctor's office.
That's a good observation.
How successful is IVIG therapy?
Depends.
I'm gaining, right now I'm on 10 ml and I'm going up to the 20 ml.
So in IVIG, intravenous immunoglobulin is using pooled immunoglobulins, and we use that to treat immunodeficiency states and certain autoimmune disorders. And we use it a fair amount in autoimmune disorders of the nervous system. How effective is it? Well, it depends on the condition being treated, and it depends on the individual with that condition. I think it is fair to say that, so we have to recognize that POTS, again, being a heterogeneous condition, is going to have a variety of causes. So IVIG is not a treatment for POTS. Now, there are some autoimmune conditions that can cause a small fiber neuropathy, autonomic neuropathy, that would be amenable to treatment with IVIG.
Yeah, I have that.
And so how effective is that? Well, it depends on the condition. And then a lot of times we're just saying, hey, with this condition, we get a good response 70% of the time, and then it's rolling the dice and seeing if it's effective for that person. And that's true whether we're dealing with a non-autonomic nervous system, autoimmune disease, or an autoimmune disease that happens to be affecting the autonomic nervous system. Yes, ma'am.
Hi, I'm just learning about this, and I'm just curious if someone has a congenital reduced foramen magnum and Chiari malformation, if that makes them more predisposed to having this or having the symptoms. And also, I'm real curious when you're talking about brain sag, because the Chiari malformation is part of the tonsils extending down in the back of the brain.
Yeah, so Chiari malformation or cerebellar tonsillar descent, so the back of the brain, you've got the hole, the foramen magnum, through which the spinal cord comes, and right above that you've got the brain stem and then the cerebellum, this hind brain. And there are people in whom the brain, those bottom parts of the brain come down through the foramen magnum. We call that a Chiari malformation, and there are different forms of it. In forms where there is compression of those brainstem nuclei, people can present with autonomic nervous system symptoms. Sometimes there are other neurologic symptoms as well, and how often does that occur and how we should screen for it, we don't know. And what do you do with the person who has a POTS-type presentation and just has a mild Chiari malformation? Is that someone that would benefit from a suboccipital decompression? We don't know. My answer would be, as of the current state, if someone has a low-grade Chiari malformation, it's going to totally depend on the clinical situation. But in many cases, it probably should not be decompressed outside of a clinical trial, because this is still a question we're trying to answer.
The main thing I'm concerned about is the opening being so small. and cutting off flow, spinal fluid flow.
If there's a congenitally narrowed foramen and magnum, it's going to depend on the clinical situation, but it goes back to that it goes back to that neuroanatomy and where is the problem. It's like, look, if there are a lot of problems that it's like, yeah, that really fits with brain stem, and then we do imaging and that foramen magnum is super tight and looks like it's compressing the brain stem, we might be like, hey, we're not 100% certain, but if there's at least some rationale there, talking about a surgical approach could be appropriate. But yeah, it's a challenging topic, but it can be approached logically and neuroanatomically.
And then you said brain sag.
Yeah. So very, very loose term, and how many people diagnosed with low-grade Chiari malformations have a spontaneous CSF leak, have low CSF pressure? How many people are diagnosed with low CSF pressure and just happen to have a low-grade Chiari malformation? Okay. This is hard. So that brain sag is just when the CSF pressure is low, we can actually see the cerebellar tonsils coming down into and around the foramen magnum. Yeah.
This is all new to me also. I'm here on behalf of my son. He's 19. Last year, he just, well, do you think, in your opinion, can major stress, he thought he had testicle cancer. And ever since we were driving to the doctor's office, and is when he told me that. First he told me he couldn't breathe, he looked green, he just didn't feel well, and ever since then he's had all of these symptoms. We've had a tilt table test. He turns this greenish color, and he sits down. He's like, Mom, I'm going to pass out, and he sits on the ground. And they told him he had the Dysautonomia. I can't pronounce it, but he was really fine. He was working a lot, and everything was going great until then. And ever since then now, he's got all of these symptoms, and we're just trying to figure out. One doctor said he's just being lazy, he's tired, he's always tired, and he's like, he has brain fog. And he tells me, he's like, I try to take a deep breath, and I can't get satisfied. I know my son. I know he's not being lazy. I know he's not being just trying to come up with stuff. So I'm here trying to find answers on what could major stress have brought these symptoms on. I don't know.
So I guess to simplify the question, can significant psycho-emotional stress drive the symptoms of a dysautonomia? I think the quick answer is definitely yes. Vasovagal syncope is actually a great model for how stress can induce a longer lasting response. So with vasovagal syncope, the common mediator is an overwhelming adrenaline response, out of balance to the noradrenaline levels in the body. And that's often driven by emotional states. So when people get queasy and faint at the sight of blood, that's purely emotional, right? There's no intrinsic problem with that person's physiology. However, when someone faints, the brain learns really quickly. Our brain is always reprogramming itself. And we definitely see in a lot of people that faint some type of classical conditioning where the brain at some level learns, oh no, this is when I feel bad, this is when I faint. And that drives an adrenaline response that makes people faint and reinforces that, oh, see, I knew I was going to faint. And this is happening on subconscious levels. And these are actually things that we target in people who faint frequently and have a lot of success with. And I think you can use that as a model for the mind part of the mind-body connection in a lot of dysautonomias. Now, a lot of other things aren't going to be directly contributed to by psycho-emotional stressors. Like having a significant stressor probably isn't going to be causing someone to develop a small fiber autonomic neuropathy. So it really depends on the clinical setting, but yeah, emotional stresses absolutely play into our autonomic nervous system. Remember, they're highly integrated. So all of those, in fact, that central autonomic network, a lot of those structures are right next to, or are the structures involved with mood and behavior. And that makes sense from a survival standpoint. Like, look, if you've got to react to something, you need all of those things to work quickly in conjunction with each other. So, yeah. How's that for a wandering answer? Thank you so much for being here. To let me share with you and to share with each other today. I hope that it's been helpful.